some questions that have come in advance and more being collected.
So you actually touched on this a little bit, and I'll start there while questions are coming up. Can you talk a little bit more about sequencing? What are we beginning to hear? What are we anecdotally about the order of treatments, number of doses, and so on?
Yeah, I think that we don't know nearly as much as we'd like to at this point. The most important fact that we do know is that if you start with one medicine and don't have a successful response, you can still respond to the other medicine, and that works in both directions. We've all heard about patients who have started with anti-PD-1, maybe responded for a while, and then had a recurrence, or maybe perhaps never responded at all, and then had a very nice response to ipilimumab, and vice versa. We've heard of patients who have had disease progression after ipilimumab, and then had beautiful responses to anti-PD-1. Whether there is an advantage to one sequence or the other is unknown. That's the subject of some clinical trials right now.
And on the subject of brain mets and other difficult disease, what is the science telling us about that? And assuming we tackle brain mets and are successful with immunotherapy, what will be the next frontier for difficult disease in melanoma?
So I'll be interested to hear what Dr. Topalian says, but brain metastases are a particular challenge for a few reasons, but we do know that there was a clinical trial that was led by Dr. Kim Margolin looking at ipilimumab in patients with brain metastases, which showed actually that there can be durable responses with ipilimumab even in patients with brain metastases. What was important is that that trial had two cohorts. One were patients who were chronically needing steroids like Decadron to control their symptoms, and one cohort where the patients didn't need Decadron. The group that didn't need Decadron were the ones who benefited. And so that's a very important part of the challenge in brain metastases, that the symptoms are controlled by immune suppressive medicines, and those can interfere with the activity when they're used up front of immunotherapy. Dr. Harriet Kluger at Yale is currently doing a trial of pembrolizumab in patients with melanoma brain metastases. So hopefully we will learn a little bit more about what the activity of PD-1 blockade is in that setting. Do you know anything?
Yeah, I don't think I have anything to add.
Okay.
There are a number of questions that relate to the label that Keytruda was awarded in its recent approval by the FDA, that is for patients who have received prior ipilimumab and or a BRAF inhibitor if eligible. Can you comment on that and what we should all be hoping for?
Well, that approval was based on very early clinical trial information, and so of course we're hoping to see approvals soon in the first-line setting, and we know that the drugs can be effective in melanoma in the first-line setting. I mean, the information is out there, but most of this information is from early clinical trials, and the landscape is evolving very rapidly. The phase 3 trials are ongoing now with several hundreds or thousands of patients, and I think we'll all have more confidence when we see the results of those trials and how these drugs should be used.
Yeah, I think right now the drugs, I mean, pembrolizumab was approved based upon the particular set of data that was submitted from the phase 1 trial. I don't think that there's any scientific or medical rationale for why someone would need to receive ipilimumab or a BRAF inhibitor beforehand, but at our institution, I'm sure at Johns Hopkins as well, we have to follow the label right now, because otherwise that's actually considered insurance fraud. And I don't think you'd like to see either of us in jail. Orange is not the new black for me. So I think that one thing that is also true is that there is not a number of doses of ipilimumab that is specified in the approval. So I think patients and physicians can talk about that, whether you need to receive all 4 doses of ipilimumab or whether perhaps just 1 or 2, repeat a scan, see how things are going. That's an individual discussion.
And on the subject of being flexible with regards to treatment with therapy, what about combinations and how patients kind of align their care and discussions with their doctors? What I'm trying to get at is there a strategy patients should be thinking about for the future in the, well, if 88% holds true or 80% holds true, then it may be less of a consideration, but should patients be considering a strategy in their conversations with their doctors of, all right, if we go with this one first and this one second, then if something goes wrong, I'll be set up for the next trial with might be oncolytic virus therapy or something?
I think it's hard to know. In all honesty, I think that I try to make decisions with my patients that reflect what's available to us now, what trials are available now. Because sometimes if we try to think too far into the future about what might or might not be happening, clinical trials that we think would be terrific opportunities sometimes don't transpire in the time frame that we want. So we make the best decisions we can together based upon the information available at that moment.
Yeah, clinical trials are still a primary option for patients with stage 4 melanoma, and I think rather than trying to piece together an individualized therapy, because this is the, maybe the first thought that people have because they heard about something dramatic that happened on a trial or whatever. Really, I think the best path is to enroll on clinical trials if you are one of those people who wants to be part of a groundbreaking effort to move the ball, to advance knowledge further. I mean, that's how we have gotten to the point that we are today, is by people enrolling on clinical trials.
I have a couple questions here related to side effects. One related to sort of long-term side effects, or what I tend to think of as long-term sequelae of immunotherapeutic treatment, and the other specifically vitiligo, and vitiligo in the context of treating other diseases, not melanoma. Is that seen in those kinds of settings as well? And then on the long-term consequences of immunotherapeutic.
So vitiligo has only been seen in the melanoma patients, and we've seen this going back 25 years when we were developing interleukin with the adoptive cell transfer therapies and so forth. There's always a small group of patients who develop vitiligo. Sometimes we even see it in patients receiving chemotherapy like DTIC or temozolomide, and it usually is a promising sign for us, because many of those people do respond to whatever the treatment that they're on. But the fact that we don't see it in lung cancer and kidney cancer means that it really is a hallmark of a specific immune response against the tumor, against melanoma, that is also spilling over to destruction of normal pigmented cells. Melanocytes is what they're called.
Is there any evidence that a vaccine or a local therapy of some sort can goose up the immune system for a non-responding lesion where there are responses in other lesions in a patient?
I think it's possible if we think about that radiation effect that I showed you. What we do in the context of single lesions or 1 or 2 lesions that are not responding when the global picture is improving is we often go back to very conventional thinking in oncology, and we even speak to our surgical colleagues about removing those so-called breakthrough or escape lesions. And I've certainly had people who've had single lesions removed surgically after ipilimumab, and they've gone on to do well in the very long term. Or they could be injected or irradiated. So I think that there is a long list of ways to try to address these so-called breakthrough lesions. And I think one of the sort of secondary gains of these medicines, the CTLA-4 and PD-1 blocking medicines, is that even if they don't allow for the elimination of all the disease, if they just slow the pace down enough for you to be creative, and use surgery or radiation to control isolated areas of recurrence, that's a very good benefit, because it is something that in the context of the disease more globally getting worse, you never would have been able to do that. I mean, Dr. Topalian, of course, is a surgical oncologist, and she would probably agree with me that someone who had 25 metastases progressing all at once, that wouldn't be an optimal surgical scenario. But someone who had 24 of those metastases that stopped growing, but one that continued to march to the proverbial beat of a different drummer, might be something that would be worth removing.
Yeah, absolutely.
Suzanne, could you talk a little bit about melanoma subtypes, not sun-exposed melanoma, and what the role of immunotherapy is for those types, for example, acral, mucosal, ocular?
Yeah. So about 50% of melanomas, that's a really rough estimate, but let's say about 50% are related to sun exposure, and the others are not. The others are related to mutations, genetic accidents, which can be random, but can create a scenario that drives the formation and the progression of cancer. We have found that immunotherapy can be effective in sun-exposed or non-exposed melanomas, and I don't think it's been looked at in a formal way. Now, whether the sun-exposed, which are believed to have more mutations, whether they may be more responsive. So that is the subject of ongoing research. From what you've heard from several speakers today, it may be so that the tumors that have the largest numbers of mutations are going to be most susceptible to immunotherapy, again, because these mutations create new proteins that can be targets for immune attack. So it's what we call a testable question, and it's something that is being looked at in the laboratory now. But yeah.
Yeah, I think actually Dr. Jason Luke, who worked with us and now is at the University of Chicago, actually had some recent publications around this area of the response to immunotherapy in melanoma, these rare sort of sun-related subtypes. So I think you've got a real expert in the room here. And if I could summarize his elegant work, is that these medicines can work even in these non-sun-related subtypes, but perhaps at a lower frequency. Did I get that right? Okay.
On the subject of, we've talked a lot about checkpoint blockade, which is really very promising, obviously, given the 2 approvals for anti-CTLA-4 and anti-PD-1 antibodies. In the category of other immunotherapies, you presented adoptive cell therapies, vaccines. There's, of course, oncolytic viral therapy is on the horizon. Is there anything else that we ought to be thinking about? Stem cell therapy, anything of that nature that folks have in mind? Or is it fair to consider adoptive cell therapy as a kind of stem cell therapy?
I wouldn't consider it stem cell therapy because they're not self-perpetuating cells unless you endow them with those properties by putting certain genes into them. But we're cutting a fairly wide swath here already, and if you add the interleukins, which are still in play, so there are newer interleukins like IL-15, IL-21, et cetera, and then you think about all the possible combinations of those drugs, I think we really have our work cut out for us.
Yeah, I think that's an important point, that we focused a lot about these talks on the molecular breaks of the inhibitory checkpoints, but there are also a lot of activation points that can be further accelerated, if you will. And so there are several medicines in clinical development that are in clinical trials right now, medicines that augment the CD137 pathway, that augment the OX40 pathway, that augment another pathway called the GITR pathway. These are all sort of accelerator points. And there are now antibodies and also other proteins that cause those accelerators to be pushed down a little bit harder. Those are as you kind of survey the clinical trial literature, those are more complex trials to do, because the experience thus far with agents like that is that they can be quite dangerous even at low doses. There have been deaths due to some of these drugs given by themselves at remarkably modest doses. And so if you get into a study that randomizes you or has you go into a group that has a vanishingly low dose, that may be perfectly appropriate for one of these step on the gas drugs, because you might only need a small amount as opposed to the amount of medicine that you would need to block one of the braking mechanisms.
So just to wrap up, I really just want to say thanks to all of you for your attention and for participating in this session. I think what you've heard is that we are living in a time of incredible progress, that these accomplishments that are coming out right now that are benefiting patients in melanoma and many other cancers day by day based on the results that are coming out have arisen because of research. Some of that research being done in the lab, some of that research being done in the clinic, and some of it being done bidirectionally with communication across both of those domains. So it's incredibly important to support that research in whatever way you can, whether it's being in a trial or whether it's supporting your local center or your favorite foundation. So just really thank you for your attention, and I want to thank our speakers for today's session. Thank you.